all of you in today's session and to this knowledge sharing forum of the African Cancer Research and Control ECHO program. My name is Annette Nakaganda and I'm going to lead the session today. I'm a cancer epidemiologist at the Uganda Cancer Institute, and I really want to welcome those attending for the first time in a special way and to let you know that these are continuous series this month of May for sharing knowledge about COVID-19 and cancer control, in particular care, prevention, and palliation, diagnosis, early detection, and so everything we have to do. So today's session in particular, as you look at the agenda that was supplied by Mishka last week, it is about learning the experiences of COVID-19 lockdown and its impact on hospice and palliative care patients. We also want to explore considerations of adapting patient care to continue with access to palliative care and end-of-life care services in this pandemic. As you all know, it may take us some time to go over it. I therefore welcome everyone once again to this important discussion. And I would like to remind you that we shall have two short presentations, one as a case and one as a didactic one. The way it is on the agenda that it was supplied to you. And then later we shall have protected time to discuss these presentations and ask questions and also comments and suggestions on how we really need to improve on palliative care services in the COVID-19 era. So I would like to remind you to mute your microphone, please, if you are not speaking. And if your bandwidth permits, please turn on your video. We like so much to see your faces as we discuss this and interact with each other. You can use also the chat window at any time to introduce yourself, ask a question, or make any comments. We shall be recording these sessions and will be sent out after each session to all of you who shared your emails with the African Cancer Research and Control ECHO. So at this point, allow me invite our first speaker, Eunice, and I'm going to introduce Eunice briefly. Eunice is a trained palliative care nurse with over 33 years of experience in palliative care and 38 years in health care, including training of healthcare professionals and home-based palliative care groups. At present, Eunice holds a portfolio as the director with Hospice and Palliative Care Association of Zimbabwe, commonly known as HOSPAZ, a national body that promotes palliative care and supports palliative care providers in Zimbabwe. She's a member of the core team that is leading the process in integrating palliative care in Zimbabwe's public health program. So we are excited and honored to have Eunice on this forum today to really share about this important aspect of cancer control and care, especially in this era of COVID pandemic. Eunice, you're welcome.
Thank you so much, and thank you for the invitation to be sharing experiences and also the impact of COVID-19 as we implement or as we provide palliative care. The next slide, thank you. Next slide. Can I have the next slide?
Yeah, Christine is trying to move the next slide. Maybe she's done. Right. Christine, you are muted. Please, can we have the next slide?
Sorry, it's Mishka, and I'm on the next slide now. Is it visible?
No, it's not.
Slide 1, Zimbabwe background?
No, we can't see.
No, it's not.
Yeah, so.
Let me try one more time. I had it before we started, remember?
Yeah, and it was working. IT is IT anytime.
Doesn't like me.
Like that. Yeah.
Are you seeing the title page?
There isn't anything
No,
yet.
we are not seeing anything apart from seeing that Mishka has started screen sharing. Yeah,
Apologies. One more time, allow me to try.
it's fine.
Or can I attempt from here?
Sure, that would be fine.
With this new Zoom upgrade, will it allow her to do it when she's on the host?
I've allowed participants to share.
To share. Oh, excellent. Yeah.
I'm trying one more time here.
And then we see.
Yes, yes, it is.
No, yeah, let's see.
Eunice, do you have the slides yourself? Maybe it will be easier for you to share.
Let me try to go into share and see what happens.
No, I can also try if Eunice if your slides are far from your screen. Mishka, how do you want us to proceed?
Yes, yes, if you can.
Can you see it? I'm trying to share.
Yes,
Yeah.
Eunice, we can see yours.
Yes.
You can see mine.
Yeah, you can just make it a slideshow, Eunice.
Slideshow now.
More,
Wait.
just down at.
Yes, yes, there you are. Yeah.
Excellent.
Can you all see?
Yeah,
all
we
right.
are seeing the first. Yeah, excellent.
Okay.
So you go on.
So I'm going to start.
Yeah.
Thank you. So I will start with the Zimbabwe background. I think it's important for us to understand where we are coming from as Zimbabwe. So the first imported case of COVID-19 was reported on the 21st of March. And a few days later, there was a local transmission that was then documented. So it was on the 24th. As of 19, but I think I will say as of yesterday, we have 48 COVID-19 cases which have been confirmed and 4 deaths. But we all know that globally, omission of palliative care into the strategic preparedness and response plan, WHO February 2020, influenced Zimbabwe omission despite lobbying from the local palliative care community. And the whole world is grappling with COVID-19 that has seen thousands of people losing their lives, including healthcare workers. So with this background, our experience and impact of COVID-19, when the lockdown was announced, it almost meant run and take cover. Honestly, the way the message was presented, it was like we were being told to run for our lives and take cover. And also, in addition, palliative care managers had a responsibility to ensure that staff were safe from the risk of getting COVID-19. And therefore, COVID-19 disease, it comes with it with a lot of fear, stigma, and the unknown, to the extent that in our experience, palliative care practitioners themselves are scared to attend to anyone with suspected of having a diagnosis of COVID. And the infection prevention measures for COVID-19 makes it difficult to monitor and follow palliative care patients. For example, if you are in contact, you are immediately told to go into isolation. And for many palliative care providers, isolation can mean cut off from the world, and hence no more providing further palliative care provision. And currently, our own designated COVID-19 facilities are ill-equipped in terms of infrastructure, equipment, and quality of services to provide befitting services for our patients. And therefore, palliative care providers know that should they get sick themselves, these are the facilities that are there, and therefore they are afraid of getting the disease as they provide palliative care services. All this, coupled with stringent lockdown laws, have made it even more difficult for palliative care providers to do home and hospital-based patient care. Since the start of COVID-19, a lot has been said about PPE. And therefore, for palliative care providers, if you have got enough equipment, there is a little bit of confidence. But in our case, shortage of PPE and local palliative care COVID guidelines has made it even worse for palliative care practitioners to continue working. How to maneuver in this unknown environment, which actually poses a lot of risk to the care provider. And also, again, we know that continuous real-time exchange of reliable, accurate information remains an integral modality of mitigating the effects of the virus. But we all know that the virus is very evolving. I also had an opportunity to read the New York article on children, the toddlers who had syndrome which was associated with COVID-19. And therefore, again, relying on social media. It is human nature that when people are in danger and they don't know what to do, they rely on any information that comes around. And a lot of this information on social media is flying around so much that it's also affecting the palliative care providers with this information which is not accurate, which actually makes them more afraid to provide the services that are required. Some COVID trainings here in Zimbabwe have been done, and I'm also had an opportunity to be trained. However, it was very unfortunate that the palliative care component was significantly silent. There wasn't anything about palliative care, despite all the advocacy that has been taking place in the country, despite the fact that we are actually in the process of integrating the palliative care in the public health system. It was very silent. So we had to bring it up. Again, it shows how the palliative care providers are just groveling around without enough guidance from the leaders. Now, when we talk about patient access, access to healthcare facilities has been a challenge for cancer patients, in particular when they wanted to go for their treatment, in particular when they wanted to go for reviews. Why? It's because of the lockdown and the stringent laws which I talked about. They were asked to produce a documentation which tells the law enforcement where they were going, whether they were going to health facilities or not. There is fear all around. This is for patients because they are also afraid to go to health institutions in case they get COVID from there. They know patients who are sick or families, they take their loved ones to hospitals. So our own palliative care patients are also afraid to go to institutions in case they get COVID from there. But even health care workers also, they shut their clinics, they shut doors, and including palliative care providers, we all closed our offices and we all sent messages all over. We tweeted to say we are closed, we are working from home, and that has an impact on our palliative care patients. So at times, when we started, even us here, we had to all rotate so that we don't have contact, a lot of contact outside your own homes, again, which provided limited staff on duty to provide for services, and therefore only looking for emergencies only. And fear, again, from our own families. I would want to say a testimony. About 3 weeks ago, I got a telephone from a family around 9 p.m. to say that they needed me to go and give an injection. So to start with, I was also startled. And I asked what that injection was all about, only to learn that it was diclofenac. The child is HIV positive, and he had hurt his leg, and therefore he had had diclofenac given by the doctor at his own surgery. And then they were given another ampule to be given at home. When they tried to get the doctor again, he was nowhere to be found. When they tried to get the nurse from that, there was no one. And eventually they got hold of me. But when I then said, yes, I was going to do that, my own family, they were so stressed. They thought I was going to contract COVID. And also if I bring COVID, I was going to spread it to everyone. So I left the home when everyone was just in a state. Only after a few days, the family phoned to thank me because the child was up and about now. The child was actually also helping with chores. And my family, I remembered my husband saying, I'm very sorry. I wanted to bar you from doing a good deed. So even our own families are afraid of COVID. Changing the way we do business. We have made telephone calls before. but it was different. We'll make a telephone call to a client or to a patient, and you will know that after a couple of days or and so on, you would follow up to check what you would have advised over the phone was working or not. But this teleworking, telemedicine is new for everyone. And not so many people are confident, including palliative care providers. One of the palliative care nurses said to me, on assessing pain and symptoms, I use my eyes, my ears, touch, smell, etc. But now relying on only phone, I'm not confident. And yet another said, I asked the patient to take and send me a photo of himself. So you can see that there is some uneasiness, and therefore is affecting the way we provide palliative care. I know so many people are on WhatsApp groups. I too, I am on WhatsApp groups, so many of those, but it also has its own issues. I know many people talk of confidentiality issues, but however, yes, people have been very innovative. They will post on the group, and then individually they will attend to the client or patient individually, but it still is not the same. So introducing this teleworking and telemedicine, I think we need to introduce tele-teamwork, where people can check, where we can support each other through the phone, and also checking with our colleagues whether we are doing the right things. One of the providers, this one is a very senior palliative care provider, and he said to me, you know, we are dealing with medicines, and morphine is a controlled medicine. So if we abuse it, it will not work well for us after COVID. So to provide the doses of morphine, to provide aiding medicines on the drug list, we are not so sure if you are not seeing the patient or assessing the patient on you, or not virtually, but when you actually go to the patient and assess. Yes, we are doing minimal contact. However, so many challenges which I have been told about. If our palliative care patient dies at home, the issue of death certificate is a nightmare, because then the authorities would want you to justify whether it was related to COVID or not. And therefore it is a nightmare as we work in this environment in terms of providing palliative care. I do have some questions. How well are palliative care providers prepared to deal with COVID-19? Or are they being thrown in the deep end? Or are we throwing our teams into the deep end? How can palliative care providers be supported with this new way of working? This is telemedicine, which we never heard of before. There's need to strengthen the support system. Psychosocial support, which includes bereavement, is dependent on effective communication skills. How best can it be enhanced virtually? I would like to uphold palliative care providers for their innovations, because they are trying definitely. We have had so many of these webinars, so many of these Zooms trying to support each other. They have had so many innovations so that we can continue providing our palliative care services to our patients who need. And therefore, I would like to uphold them. Otherwise, before I end, I would like to acknowledge the ZIM palliative care team and Cancer Association. Thank you.
Oh, wow. Thank you so much, Eunice, for really that awesome presentation. It really brings, you know, the context very well, and you've really shared the universal issues that are happening in Africa. And actually, very well, you pointed out the dilemmas for discussion. Dear colleagues, once again, I want to remind you that we shall have protected time at the end for discussion and comments and suggestions. So please take note of your question now, or you can use the chat window for posting your question. We shall take care of it at the end of the next presentation. So at this moment, I'm greatly honored to invite Zipe, Dr. Zipporah Ali, who is going to take us through the next session. Allow me briefly introduce Dr. Zipporah. Dr. Zipporah Ali is the executive director, or is the executive director of Kenya Hospices and Palliative Care Association. It is KEHPKA. She serves on the board of several organizations, both locally and internationally. She's involved in advocacy of pain relief and palliative care for children and adults in Kenya and globally. She's a recipient of several global awards, including honorary doctorates from both Oxford Brookes University and the University of Dundee. She worked in Nairobi Hospice for over 16 years, initially as a volunteer and later as a senior medical officer. Dr. Zipporah, we are really excited and everybody is looking forward to hear the considerations we are going to take, especially in this COVID-19 pandemic era, towards palliative care. And please, take over the floor.
Okay, so good afternoon, everybody. Those in Africa, good afternoon. Those in the US, good morning. And well, good something to everybody. Yeah. So I'm glad that Eunice set up this discussion, because the things she has talked about are real and are things that we are facing all over the world as clinicians, not even just as palliative care clinicians, but also as people involved in patient care. I think most of you here probably know what palliative care means, and I will not really read the definition, but I think we know that we are focusing a lot on the quality of life of our patients and their families. We also focus a lot on patients who have got serious health-related diseases or people who have got life-threatening illnesses. And I think COVID-19 is very, very, part of this. I think COVID-19, actually, if you ask me, is the one that needs palliative care more than any other illness now, because it is very sudden. It is a new disease. We don't know much about it. It is taking our family members away from us without even preparing us for this kind of thing. With cancer patients, we usually have time, and maybe we have what we call anticipatory grief, but in this kind of situation, things are really very difficult. So we focus mostly on relieving symptoms, whether they're psychosocial or physical symptoms, spiritual symptoms. But the things that we really focus on a lot also is our relationships with patients themselves, relationships with their families, and also relationships within the team members that work together to provide these services. And also, of course, good communication, assessing symptoms and being able to treat our patients. So I think COVID-19 has really brought us a lot of challenges that we need to focus on. And as Eunice said earlier on, when she said she was surprised that they had not involved COVID-19, palliative care into COVID-19 in Zimbabwe, it's not something new. It's something that we currently are facing even at the WHO level. We have been attending the WHO meetings the last 2 days online, and all the leaders from all the different countries, not one single one of them mentioned palliative care. So it is a very big challenge, but luckily WHO has a resolution that actually now includes palliative care as part of the COVID-19 response. So we need to be prepared. We need to prepare our healthcare providers to be able to deal with COVID-19, not just for our regular palliative care patients, but for anybody who contracts COVID-19 and their family members and their community. They will need a lot of support. So of course, in palliative care, we usually focus on symptom management. And for symptom management, we need to have good assessment tools, like Eunice has said. We need to have the necessary medications for patients, including especially opioids, which are rare in some countries or given under very strict laws. But luckily, for most of the African countries, actually, our laws are very friendly towards having opioids for pain management. And COVID-19 has similar symptoms to the ones we see in palliative care, especially end-of-life care. Things like, fever are things that are common in our patients, cough, secretions in the larynx, all those things are things that we come across, constipation. So these are the things that we really do every day with our patients. We just need to be able to take our skills and now also apply them to people who have got COVID-19. Breathlessness is a very common thing in cancer, for example, lung cancer, breast cancer. Most cancers will metastasize to the lungs, and we have all these things that we usually have to do for our patients. For example, even in breathlessness, using oral morphine to control, to ease the difficulty of breathing, which is a challenge because most doctors do not want to prescribe morphine when a patient has breathlessness, because the myth has always been that if you give a patient morphine, they'll go into respiratory distress and die. it is important to understand how to prescribe it, how to titrate it, and what level to start when you're giving to a patient who has got a problem, difficulty in breathing. And I know in Kenya, we haven't really used it in the COVID-19 yet, but Dr. Weru, who is a colleague of mine, has been able to actually use it in Aga Khan Hospital for patients who have got COVID-19 and are having difficulties in breathing. So symptom management is very important. Whether the person is dying or not, we have to be able to ensure they have got a good quality of life and that we are controlling their very distressful symptoms. So really, when you're controlling symptoms, you are aiming at having comfort a day, at night, relieving the patient from pain, reducing all those other anxieties, just having as much as possible a life that you'd have on a daily basis, but not maybe the same quality because you're unwell, but trying to maintain some level of control and quality in your life. So like I said, it's not only about physical symptoms. We also talk about psychosocial, cultural, and spiritual aspects of care. And for people coming from countries in Africa, culture is very important. We have to always respect our patients and their families' culture and work within the context of their cultures. But we need to be able to have a very good communication skills to do this. Otherwise, you end up offending somebody and they'll not come back to the clinic. So psychosocial and spiritual care is very important. Spiritual care in Africa is always confused as religion, but I think it's something that we do because we actually mix spiritual and religion, being a country and a continent that is very religious with different types of religions. We have Christianity, we have Muslim, we have Hindu, but these are all people who have got a very strong faith and also have a lot of spiritual components in their faith. So we have to also think about that, things about connections. COVID-19 is posing a very big challenge for us because patients, once they go to the hospital, you cannot visit your patient. If they get very sick and die, you will not even have had time to say goodbye to these patients. And then, of course, once they die, they are taken, they're put in a body bag, and you're told to bury your patient within 24 hours, and you're only allowed to be about 15 people in Kenya, 15 people at a funeral. We come from a society where a funeral is where everybody comes to say goodbye and mourn and support each other. But now there are normal cultural things and traditions are really being violated because of what has to happen around this mysterious illness. So those things are also becoming very affected. And the other thing is about when somebody dies, what happens to the body? In some countries, they have not even seen the bodies. They have just been, cremated and buried in probably mass graves. This is not something that a family member wants for their person, and it's something that is going to cause a lot of psychosocial, mental issues in the families and in the community. So there are many things that we're actually facing at this time of this pandemic. So again, end-of-life care is very important. Of course, we should always try to treat, to cure. If we can cure where it's possible, we should always try to cure. If not, at least alleviate the disease. And if they're dying, be there for the patients and their families at end-of-life care. So end-of-life care is very important. You have to identify that a patient is dying, communicate the same, the same to the patient's family, address their psychological, spiritual needs, and if possible, like Eunice has said, facilitate communication between the patient and the family. And we're doing a lot of this now through, social media, through our smartphones, trying to even make them have a video call if possible, because it's important for them to get to be able to see the patient and also to be able to say goodbye. And if it's still early enough for the patient to talk and communicate, for them to also get their businesses in place, address also their unfinished businesses. So those are very important things. So communication is really, really key here. Symptom management, communication, psychosocial and spiritual support are very important. And also just trying to make sure the patient has a sense of control, and even the family. Right now, they don't feel they're in control, because if in Kenya, if they come to your house and they test you, you're taken, you and your family, into a facility, which has, which is really not a very good facility. The beds are terrible, the toilets are bad, the food. So you really are not in control of what happens when in that facility. And if the patient goes into the hospital, you have no control of what happens to them in the hospital. So these are very difficult things. And the other thing also is also documenting whatever we are doing with our patients, because we do not know what will happen in future when people come back and say the things you did were very unethical. If you look at Italy, they had to make decisions whether to treat somebody or not, depending on their age, on their pre-existing diseases, which is not really the decision we should be making. We shouldn't have fallen into this kind of a state because everybody, whether they're elderly or whether they have another NCD or other illness, have a right to being treated and have a right to be being treated with dignity and not making a choice for them to die. Many people in old people's home have been left to die because after all, they are dying, they're old. Those are really things that we are going to have to deal with in future. And we hope that those decisions will not come to us in Africa, that we need to be, we have had a chance to be, with 3 or 4 months of preparation, we need to be well prepared for these kind of challenges. So the ethical issues, whether the patient should go to ICU or not, are very important. Once they're in ICU, do they continue treatment or do they hold treatment? Things that usually you will discuss with the family or you'll discuss with the patient before they get to this kind of state. We don't have the time to do those things now with our patients in COVID-19. So those things are very challenging for us. Things like palliative sedation, which are very common in the Western culture, but not very common here, are things that might even start coming onto a doorstep. If the patient is very agitated, very delirious, how do you control this? Because they are literally dying, but they are dying in so much pain, you need to be able to sedate them. So again, things of bereavement, like I said earlier on, caring for the family. We are thinking in Kenya of setting up bereavement services, not services, but kind of bereavement support for people who are losing their family members through COVID-19. You know, even for that, as professional caregivers, how do we handle some of these things? So for example, last week, we had a training of about 7 hours last week on Friday for palliative care clinicians. It was being done through the Ministry of Health and Red Cross on just the psychosocial issues around COVID-19 to be able to support themselves and also support families and patients who are affected. So those are very important things because if we are not ourselves mentally well equipped, we'll not be able to handle this. We're going to burn out and we'll have a lot of other things that we'll need to deal with. So we really should aim to cure sometimes where possible, to relieve often, and to comfort always. And as the founder of the modern hospice says, we actually, whatever we are doing to our patient must convey a message that you matter because you matter to the last moment of your life. And we will do all that we can, not only to help you die peacefully, but to live until you die. So whatever we are doing with our patients, whether we are dressing them up, changing, turning them, or whether you're talking to them, or they're giving them some injection, or whatever we're doing for them, we should be able to convey in our actions and words that they matter to the last moment. And so this is also becoming very difficult because there are very few people working in ICU at this time, and so they don't have time to be able to do these things properly. So again, we need really to be able to upscale our training so that people are able to do these things. So for end-of-life care, I think we have to be able to recognize that they're dying. We have to communicate this to the patient, maybe, but also to the family in a very sensitive manner. We have to support the patient and the family, and also we always have to make a plan. If the patient dies, if they become very sick, they can't talk, who is their voice, who is going to tell us what they want, what happens to the body once they die. All these things are very important things. So we need to remember those as well. So social distancing, like I said, has caused a big problem. We have people separated, patients separated from their families separated from each other. Even now as we speak, some of you have not seen your parents or your children who are out maybe working in a different place because you have to be isolated. So that is also a very big challenge. And so we need to be able to try to find ways, like Eunice said, how can we keep on communication? So one of the things I'll talk a little bit about later on is that we are supporting, KEPCA, my organization is supporting hospices to actually have smartphones where they can even video conference with patients. For the palliative care patients who might even be having a wound that is not getting well, you can see the wound from the video and maybe give information, talk about medication and all those things, and just have those family conference calls on phone if it's possible. So again, modern technology is becoming the thing right now. We're doing a lot of our trainings through Zoom webinars and all those things. We probably will have to adopt this kind of communication until further. And so we have to be very innovative in what we are doing. So just before I end, I just want to share a survey that we did about 6 weeks ago, when we actually realized that there are many challenges that our hospices and palliative care units in the hospitals, public hospitals and government hospitals are facing. We looked at some of the challenges they might be having, and we had a few questions. We had asked them about what changes they have brought about in their centers and what challenges they're facing and how they're addressing these challenges, if they're able to reach their patients, and if they're able to reach their patients, what are their fears and concerns that they're talking about the patients, and what they would like us to be able to support them with in many ways. So we had interesting, I have a whole report I can share with you later on. I can give to Mishka to share with the people on the call. So there are many changes. Some of them are not having the 5 days, Monday to Friday clinics. They are actually, now you could walk into a hospice before, a clinic before, but now you have to have to make an appointment because they want to ensure they're following the regulations of social distancing, hygiene, and all those things. They all have now, water and soap and sanitizers at the entrance. They have masks for the patient to come in. They're all doing all those things, but this makes them feel also very strange because in palliative care we live a lot in really being very close to our clients. So this is also very difficult for them. Most of them are not doing home visits like they were doing before unless it's very necessary. And this was mainly because they didn't have enough information on COVID-19, and also they didn't have the PPE required for them to be able to provide services. So they were not just afraid of themselves contracting the illness, but they're afraid that since they're healthcare workers, they could easily contract COVID-19 and take it to their patients and their families. So we have all these changes that have happened. One or two of our hospitals that are providing palliative care have been asked to be COVID-19 response centers so that if patients come, they'll actually go to some of those hospitals. But there has been no equipment, no improvement of infrastructure for them to be able to provide these services. So they still have those fears and concerns about this. And just to address these fears and concerns, actually this evening we are having a call with our palliative care providers to look at the fears they are facing in terms of providing services to COVID-19 patients, because whether we like it or not, our patients might, some of them might contract the infection, but we'll also have those who are not necessarily palliative care patients, but have COVID-19 and now will need to be, provided palliative care. So again, most of our patients' fears, cancer patients mostly, well, one of them was dying in pain because they were scared that opioids would be out of stock. Usually have out of stock issues with opioids, and now they thought now with COVID-19 it will even become worse because all the resources will be directed to COVID-19. So they were afraid about their own illness and the fact that media was telling them every day, you're at the highest risk, you're at the highest risk. So they were like, okay, this is going to kill us, not even the cancer I have. So stock out of medicines, of course, and then again, clinicians not being available at any time they needed to be seen. So that was also another concern. And again, cancer services would be scaled down, which they have been scaled down in that they're trying to control the number of people who come, for example, for radiotherapy. Before we would just have a whole lot of crowd waiting, but now they're trying to scale them so that there are a few people per day so that at least they reduce the risk of infection. So all these things were done not because people are trying to be bad, but simply because they're important. These are the things that we need to do to be able to reduce risk of infection. They are scared that they might not, if they don't get their treatment, their disease will progress and they'll probably get from stage 2 to stage 3 very quickly. And so some of the fears were really genuine, contracting COVID-19, taking it back to their family members. And so what happens if I get sick and I get to the hospital, will nobody see me? What will happen to me when I die? All those things were very genuine fears. There were also socioeconomic fears with the patients. Of course, they were worried about not having masks and sanitizers, and they were worried about, some of them live in very small places in slum areas. So even they don't have enough room to isolate themselves from the rest of the family. And all those, some have to travel to Nairobi because Nairobi has the only public radiotherapy machine. So they would have to travel from wherever to come to Nairobi to get their radiotherapy. And that was really difficult traveling. For patients, okay, the counties issue letters for them to travel. But again, the transport is not available because unless you have your own transport, public transport from Nairobi to other parts of the country has been stopped. And so the lockdown has been a very distressful thing for most of our patients. And of course, most of them are small business earners. They're not able to do what they do on a daily basis to earn money. So even fear of not just not having money to buy medicines, but even money to have food, to buy their food and to pay for their rent. So these are really concerns that some of them are having, losing their jobs and the rest. So we, sorry, those are the references. So we decided that we could look, what we did after this survey is we tried to look at how we can address some of these issues to support both the caregivers and the patients. And so we were able to get one of our former donors and talk to them, and they gave us money to buy PPE. So we have been actually purchasing a lot of PPE and sending it out to hospices. and to the palliative care units to enable them to be able to see their patients and even do home visits. Like I said, we are buying more mobile phones and giving them airtime to be able to communicate with their patients, and also to take things like masks, facial masks to family members, to patients and family members, to help them also reduce the risk of getting infected. But we have also started a lot of Zoom sessions to address some of these issues. For example, not having enough information on COVID-19. We have integrated, we are working very well and very closely with our Ministry of Health to ensure they include palliative care into whatever they're doing. We have two main subcommittees on COVID-19. There's one on mental health and psychosocial support. We are part of it, and that's why they are training our clinicians. The other one is on clinical management of COVID-19. That one is a bit complicated. Clinicians are usually very complicated, but we have given them guidelines to be able to put them into the guidelines they're developing. So there are all these things that we're trying to ensure that we are still very relevant and understand that palliative care is really going to be very necessary in terms of COVID-19 response. So yes, I'm happy to share the report if anybody wants to look at it. So that is all I wanted to share today, and I'm happy to take any questions later.
Yeah, thank you so much, Dr. Zipporah, for that excellent presentation and for sharing such well-conceived suggestions and some considerations we may need to consider during this pandemic era. So colleagues, this is the time for discussion. And I want to remind you that if your bandwidth allows, we would request that you turn on your video so that we have an interaction when we are seeing your faces. Feel free to verbal put up your comment or your question, or you can put it on a chat window. I can briefly project what Eunice had, because she had dilemmas in her work, and she wants comments, she wants discussions. It looks like the way Zipe presented, Kenya is in a better shape and trying to work day and night to do this. But this is what Zipe have. So you are free to either comment on Zipe's question or put up another comment you feel you have now. Thank you.
So are we allowed to take part in the discussion?
Yes, please. Go on, Zipe, if you have a comment.
I just wanted to say, just respond to some of the concerns of Eunice. I think palliative care providers, we have the knowledge for palliative care. We are trained, we've been working, we have the experience, the skills. And what I just want to say is that we were not prepared for COVID-19. Nobody was prepared for COVID-19. Even the epidemiologists will tell you they were not prepared. And the infectious diseases clinicians will tell you they were not prepared. So every day we hear something new, we hear something, symptoms now. We are being told if you don't smell, if your nose you can't smell something, you might be having. The other day I was sick and I thought I had COVID-19. I didn't sleep the whole night because it is a new disease. So I think what we need to do is to come up with guidelines, and maybe as a community, come up with guidelines on how we can provide information to our clinicians, palliative care clinicians, especially on COVID-19, the correct information and updates every time, and also encourage them to be part of this response, because we can't just sit aside and say we are not going to do this. It's not what we usually do. We need to be able to work together to be able to do this. So I think everybody has been thrown into the depth, into the deep end, not just palliative care people, but everybody, including even the population, the public, the community, everybody's in the deep end. So I think we need to maybe think about it. How do we prepare our healthcare providers to deal with COVID-19? How do we prepare our regular palliative care patients to also deal with COVID-19? So it's something we need to look at. And that's why it's very important for us to be supportive, whether it's physical, where it's possible, with all the right equipment, and if not, with telemedicine. So also the use of telemedicine, maybe we might need to train people on it, but the use of things like WhatsApp is almost everywhere in Africa. It's very common. So that is not a big problem. And strengthening the health system is palliative care as part of the health strengthening system throughout whether it's COVID-19 or not, WHO has given a resolution saying we need to strengthen our healthcare system by integrating palliative care. So most countries in Africa, I think that's what we have been working on since 2014. For us, since 2010, actually, we've been working on strengthening the healthcare system by integrating palliative care into the public healthcare system. And we've done that in almost, out of the 47 counties we have, I think we've done it in 43 counties so far. So we need to focus on strengthening, not just standalone hospices, but ensuring that palliative care is totally integrated into the healthcare service, into the medical, nursing, pharmacy, and all the other relevant fields of medicine in training. And community health workers are also trained in palliative care. Is one of the things we're actually going to be focusing on COVID-19, to train community health workers, because community health workers will still continue to consequence the community. And so we will need to be able to give them the right information and maybe even equipment for them to be part of this team. Psychosocial support, of course, is always important. And communication is something that mostly doctors lack. And we need to focus on that as well. Yeah.
Yeah, thank you so much, Zipe, for the useful comments. As you said, everything is hard, but we are happy that the whole community is willing to learn, to adapt to this pandemic era. So, any comments, Mishka, on the chat window? Or?
There is a question on the chat, and Dr. John, if you want to unmute, you can ask directly, but it's a question to you, Dr. Zippy. Do you plan, he says he's happy to learn of the training on bereavement support to families, and do you plan to roll it out in Kenya, and how does it relate to the government guidelines on funerals in the COVID-19 era? And Dr. John, if you wanted to add anything to that, please do.
Yes, so thank you for the question. It is something we are working on right now, and maybe I'll invite you to listen to we have a webinar next week on Thursday on bereavement, and we are going to be looking at bereavement issues. What I want to say is that we are working with right now we're working with Faraja Cancer Support. Philip is a psychologist, and he has a team of other people we work with on looking how we can set up bereavement. We might not have physical bereavement support because of the social distancing things, but we want to look at maybe even coming up with pamphlets, information, a place where somebody can go. But also at KEPCA, what we are actually doing right now is getting a toll-free number for SMS, where you can actually send in your question, and a healthcare provider will call you. We are going to work with 17 hospitals in the country to be able to call you and give counseling. So we are looking at how can we do this in these times when you can't even have a face-to-face interaction. So once we do this, I think we will try to roll it in the country through the mental health psychosocial support subcommittee in the Ministry of Health, of which you are part. So it's something that, and one of the things even the Ministry of Health was asking, can you help us develop guidelines of rehabilitation? Because if somebody has been very sick, and especially has been in ICU, getting back to a normal life, we even told children lose 40% of their muscle or whatever. Getting back into a normal life, they will be discharged because they can't be kept in hospital forever. But getting back to their daily life will be a very big challenge for the patient, for the family. And specifically, the community might not even want to interact with this person because they had COVID-19. So how do we even reduce the things of stigma and trauma on the patient's side? So we are looking at how we can actually do some of these things, and maybe that can be a topic later on. Once we have these guidelines in place, can be a topic we can maybe address with Faraja, one of the webinars that you hold later on. Yeah, but it's very important. And you asked about COVID-19. Unfortunately, what the ministry has put in place is important because they're trying to reduce infections. I don't know, Alex, if you're from Kenya, I don't know if you saw the burial of there's a politician's brother, I think, who died, and the burial yesterday. It had people, all of them dressed like they're burying an Ebola patient. Everybody was in white and mask, and everybody, and this is very traumatizing even for the community. So it actually makes the community run away. So those are the things we really have to address. And
Eunice had a comment. Eunice wants to make a comment, maybe before.
Yeah. She needs to unmute herself, Eunice.
Eunice, yeah.
Okay, I also wanted to emphasize, I think the dilemma which I see with our palliative care or our health professionals is that they don't have enough to use, these basics. And these basics are the PPEs which we are talking about. And if you hear, yes, most of the other organizations with the donors who can afford, they are buying from the donor money. But I think we need to advocate so much that our governments provide the PPEs that is necessary for our health professionals, our palliative care practitioners, and everyone else to be able to use. And I think that's a setback. It definitely here in Zimbabwe, there isn't enough.
Yeah, I agree. It's unfortunate. We are supposed to have Dr. Emmanuel Lirika, who is the director of African Palliative Care Association, to really tell us, because I know he's aware of what is happening in different countries of Africa. But it looks like we are at a different level now when it comes to COVID-19 preparedness and cancer control. So some countries like Kenya, they have prepared well, and as Eunice presented, they're still figuring out actually what to do. All the palliative care clinics were closed, and all the health workers went into hiding not to get the COVID. But it's really a very important area, especially it has been important, and especially to cancer patients, but more so in this era of COVID-19. So before I say any of my comments,
can I make a comment? Can I make a comment? They went into hiding the very first time the lockdown was announced. Now we are back.
You're back.
Now, yes, now we are back and doing the work. But the very first time when they said lockdown, people didn't know what to do. But now definitely the situation is better.
Thank you so much for that clarification. Anna Mary has a question. Please, Anna, go ahead.
Hello, everyone. My comment is that, yes, COVID-19 has had a lot of adverse consequences, but we can also try and take COVID-19 as an opportunity to improve certain things in our environment. And I was thinking, as a palliative care community, this was a time to advocate for recognition of palliative care. So if the palliative care community like the Africa Palliative Care Association actually had their own PPEs, which they could distribute in countries just to actually make people aware that, there's this thing called palliative care, which is handing in PPE. We could then have a mark on the continent as far as palliative care is concerned.
Yeah, thank you so much. That's really very interesting, because unlike other cancer control measures, which were like the patient had to walk into the center, palliative care and end of life sometimes involved clinicians and health workers going to patients' homes. So that is something that really comes out as unique to this element of cancer control. I have just Zipe. You said it's good you've started having the landline, but things to do with the WhatsApp and Zoom support, I don't know the percentage of Kenyans who have smartphones. I agree that all Africans have phones, but they may not have smartphones. And many of them, almost more than 60% or 50%, are in rural areas. So how is the reality there with your experience of this landline and Zoom meeting and WhatsApp calls?
Are you asking me?
Yes, how is it going after introducing the Zoom communication and WhatsApp and?
Okay, so in Kenya, actually,
sorry, is it only in urban in Nairobi or?
No, I'm going to. Yeah, so I'm going to explain. In Kenya, let me just start with, in Kenya, we have mobile phones are very, very common almost everywhere in Kenya. Even if it's a simple, what we call mulika mwizi, which is, the one which have the touch, the simple one, the people have those phones. So almost in every home, there's a phone. And mostly this is because people use what we call M-Pesa. It is a transaction of money through the phone. And because it's a very easy thing to do, and people in the village are always asking for money from people in the cities, everybody made sure they got a phone. So they can always send you a message, I want money. So that phone, we target that phone to send simple messages as well. But also in many homes, you have young people who somehow or other manage to get a smartphone. You can get a smartphone for even $50. So you find that, so where there's a smartphone, we will use the smartphone. Where there's the other phone, we will use the other phone. But what we are doing is we're not supplying smartphones to the patients, we are supplying smartphones to the hospices who have actually told us there is somebody in the home with a smartphone, we can actually use it. I just wanted to go back to Eunice and say one thing. Kenya is not in a better position in terms of PPE. I think PPE are the same all over the world. Even as before we started this project of supplying PPE, I called the resource person for COVID-19 in the ministry, and they kept on telling me, but we have sent PPEs to the centers, they're in the public hospitals. And I would call the people in the public hospital, they say, we don't have any in palliative care. So the PPE is a challenge for everybody. We just have to ensure that our government provides it, but always they never have enough. We're talking about African governments, but we also have to find out how can we support our people.
Yeah, I agree. Christina has a comment. Please go on. Christina, unmute yourself. And
yeah, so here we are. So thank you so much. Excellent presentations. And as a clinician, I always appreciate, you know, the knowledge and the expertise of my colleagues from Pall EOL Care. And thank you again for sharing with you your expertise. I've got actually 3 very short questions. I'm very much aware about the time as well. The first one is related to the trends of palliation. Are we moving more from hospice towards home palliation? Do you see any trends? Do you see any differences in the country? That's my first one. The second one is related to the lessons learned from COVID, because I absolutely agree with you. We were not prepared, not only from the palliation point of view, but the whole world was not prepared. So if we could turn the time back, what we would have done differently? And again, I mean, I'm thinking in terms of telemedicine, which has a lot of value, but palliation, is it the same if you talk to the patient or a WhatsApp versus of really holding the hand and being physically there? That's my second one. And my third one, I'm of course, as a pediatric oncologist, would like to know some of your thoughts, if you could share with me regarding the palliation for children with cancer in the context of COVID. So anyone who would like to answer the questions, and thank you once again for a great session.
oh, it looks like, do we have time to answer these questions? Only 2 minutes to the end of the hour. So Christina, those are very good questions and points for us to think about. And as I said, we are continuing actually with this series, and one of the series we are going to tailor it to telemedicine, actually, making sure that we know which services can be offered virtually and which ones cannot. So towards cancer care, so that we really, the importance is actually not to cut off completely the seeing patients physically, but to minimize the interactions as much as possible. For example, the initial discussions with the patients are difficult to do on virtually. So I'm sorry, Christina, we may not have people. I know Eunice wanted to respond, but in the interest of time, I have to end the discussion now. But these are really very good comments, things to do with pediatrics, you know, cancer and their palliative care. You know, these children are so vulnerable that once is in pain, might be in pain, and the parent doesn't have money, they will never go out to really seek for painkillers, and the child will die in pain. So it is really, as Mishka alluded to it in the beginning, palliative care is going to be a continuous session, and if needed, we may have to repeat it again to really touch specifically on the specific issues, especially in Africa. So at this point in time, I'm going to before I call Mishka, we always have the discussions on the base camp. If there are hot issues, please feel free to continue this discussion on the base camp. But Mishka, can you please make some announcements?
Yes, enormous thank you to Eunice and Zippy for your presentations today, and Annette, as always, for managing this great moderation. So next week we'll continue again, Thursday, same time. I will be posting the agenda and the information via email. Thank you all very much for joining today. Back to you, Annette.
Yeah, thanks, Mishka. It looks like we have come to the end of this session. I would like to really thank Eunice and Zipe for sharing their great experience and their thoughts and how they think palliative care can move forward from now onwards. And I thank you all for attending this session, and please stay safe and take care. And I look forward to seeing you next week.
Thank you.
Bye, everybody.
Bye.